Hello, and welcome to the Cardiology Podcast, Why We Do What We Do in Cardiology. In this audio series, we will discuss the practice-changing articles in cardiology from the past to the present. This is your episode for today.
Today, I am going to discuss about the REDUCE-AMI trial. The study is titled Beta-Blockers after myocardial infarction and preserved ejection fraction. This was presented at the 2024 American College of Cardiology meeting and was simultaneously published in the New England Journal of Medicine on April 7, 2024. The latest study to assess the long-term use of beta-blockers in patients who have experienced an acute myocardial infarction and have preserved ejection fraction has cast doubt on the benefits of these long-standing agents. The REDUCE-AMI trial, presented at a major scientific session, revealed that beta-blockers do not reduce the risk of death or recurrent myocardial infarction in these patients. The Kaplan-Meier curves for the primary endpoint of death or recurrent myocardial infarction showed no significant difference between those treated with beta-blockers and those who were not. These findings reflect a shift in post-myocardial infarction care. Historically, beta-blockers have been a cornerstone of treatment, prescribed routinely to patients following a myocardial infarction. However, recent studies and meta-analyses, including the REDUCE-AMI trial, suggest that in the context of modern medical therapies, beta-blockers may no longer provide the expected benefits. The study's practical implications are significant. After a heart attack, patients are often prescribed multiple medications, leading to a complex regimen. The REDUCE-AMI trial allows physicians to adopt a more streamlined approach, potentially reducing the medication burden on patients. If a patient's left ventricular ejection fraction is preserved and there are no other compelling reasons for beta-blocker use, it may be reasonable to forego these medications. The findings were published in a prestigious medical journal, sparking discussions within the medical community. The results call into question the necessity of beta-blockers for patients with preserved ejection fraction who have undergone revascularization and receive comprehensive care, including statins, antithrombotic therapy, and angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. An accompanying editorial cautioned against completely abandoning beta-blockers just yet, noting that the results apply specifically to patients with preserved ejection fraction and that high-risk patients, such as those with lower ejection fractions or who have not undergone revascularization, may still benefit from beta-blocker therapy. The editorial emphasized the importance of further research to clarify beta-blockers' role in contemporary care. In conclusion, the REDUCE-AMI trial reflects the evolution of cardiovascular treatment. 5 or 10 years ago, beta-blockers were considered indispensable in managing myocardial infarction. However, with advancements in medical therapies and a deeper understanding of patient needs, the medical community is reassessing long-held practices. The trial encourages a thoughtful re-evaluation of beta-blocker use, paving the way for more personalized and effective post-myocardial infarction care. These are the main take-home points. Beta-blockers may no longer be necessary for all post-myocardial infarction patients with preserved ejection fraction. Modern medical therapies might provide sufficient protection without the need for additional beta-blocker prescriptions. Reducing unnecessary medications can simplify treatment regimens for patients. Further research is needed to confirm these findings and refine treatment guidelines. Personalized care approaches are crucial for optimizing patient outcomes in post-myocardial infarction treatment. Thank you for listening to this podcast, Why We Do What We Do in Cardiology. The information in this podcast is for general information only for medical professionals and is not intended to be a substitute for medical advice from a qualified healthcare professional. We hope you found this information helpful, and we look forward to seeing you on the next episode.